thank you to the Epilepsy Association for allowing me to do this. And thank you to all those who have taken time away to spend lunch hour with us. You know, I have been part of epilepsy since the mid-'80s, and I spent most of my time in Chicago, and my interest really has been rural health and what we now call population health. And some of that will be woven into this discussion. I've also been very interested, as you heard, in technically what we call neuromodulation. And you can use the word neurostimulation, but the question is, what is neurostimulation? We are trying to stabilize epileptic networks, but that has a bit of a rigid flavor to it. When you stimulate networks, I always thought way back when in the '80s that I was hurting the brain. And you actually can do that if you do it right, I guess, to make epileptic circuits. And we actually call that kindling. We can do that in animals and humans. We've seen this. But also you could modulate to not just stabilize, but cause new branches to form. And on our neurons, brain cells, that is phenomenal to remodel to the brain. And so I like the word modulation, and also that these circuits are fragile neural networks. And what we learned since the early '90s into the early 2000s is that neuromodulation can actually modify fragile neural networks that are also intimately related with mood and behavioral disorders. So you'll hear just a little bit about this, and they are so closely related because really the majority of our uncontrolled individuals in this country at least have co-occurring mood disorders. And those are statistics, that's why I can speak confidently about that. And that's up to about 70% of patients who get followed for uncontrolled seizures also have comorbid mood disorders. So let's start our story for better characterizing this framework of what we call neuromodulation. I'm going to talk about what it means to connect or interface implantable stimulation technology from the outside world with central nervous system circuits internally. And this is really to modulate and actually to remodel dysfunctional neural circuitry. So hopefully my slide will move forward. Okay, here are our learning objectives. If you listen closely enough here, and if I present it well enough, I think we really can pull this together in a straightforward way. Fragile neural networks really relate to what we call pathological learning. And really, in this context, that's epilepsy. And at the same time, you really can see this type of remodeling in mood disorders. What I want you to understand, we've got some acronyms here. Many of you have heard these and know what they mean, but we're going to talk about the VNS, DBS, and RNS. So it sounds a little bit like a rap beginning here. We're going to introduce also the outcome data, just some straightforward data that says, hey, this really does work. And in many scenarios and population studies, you can argue it works better than medications that have failed, and that's a big deal. We'll talk a little bit about tolerance too. That's as big a deal because when you have this honeymoon period, often with meds, in some people, that honeymoon period wears off, and you don't want to see this with something that's implanted, like, hey, this just doesn't work anymore. And you'll see some positive data there with that regard. So questions to consider. So just two, we're going to stay straightforward here. So I'll throw these out here, and if you can, again, grasp these, we got it all here. So how can electrical stimulation revert dysfunctional brain cell firing patterns to a more stable firing state? It sounds like we're going to just aim at something and break up the synchrony. We call that, the fancy singing together in a choir. When cells sing together, it sounds pretty, but it's what you don't want to see the brain do. And so that sounds straightforward enough, but again, it's more than that. We're actually adding new repertoires to those singers, and you're actually over time teaching more sophisticated patterns to where we prevent that resynchronization. And then that leads us to better seizure control. And I know this lecture there's no title words saying mood or behavioral health, but it really does impact behavioral health. And I think that's so important to talk about. We just can't let that go. So, as we begin this journey today, I want to start by making sure everyone defines a seizure in the same way. Seems basic enough, except not everyone thinks of a seizure in this way, and this is the proper way. You can think about a seizure clinically, you can think about brain cells, but we're talking about connecting technology to the brain, so you want to think about this down to that level. You can even challenge this in our Q&A. I hope we'll have time for. So in its purest definition, a seizure is synchrony. I've already talked about this, and it's really pathological learning, or if you want to say this more technically correct, pathological information processing. So, and particularly when this hits the medial temporal lobe, and some of you may be able to see me here, but I have a little brain picture. Here's a model. Here's the picture of the temporal lobe, and medially is the hippocampus, and that is the most common focal onset epilepsy. You really do teach that area to learn, like repeating something 1,000 times. And so what we're preventing is neural synchrony at every level, even below the sensitivity of some of our equipment. The electroencephalogram, which we'll talk a lot about, is 1929 technology. And actually, this year is the 100th year that it was invented in 1924 and then published in 1929. Give all the credit to Dr. Hans Berger. So we're looking at micro networks that really go below the resolution of what we can often see on the brain. At risk of overplaying the term public health crisis, as we've heard so often over the last 3 years, I want to tell you that not considering patients for epilepsy surgery, whatever that means, we'll show you very quickly, it's been labeled a public health crisis. And that has been going on for about a decade now. And here's why. So of the, let's say, just under 3.5 million, there's 3.4 million. I actually think there is more than that. And every few years we see those numbers go up just because we're becoming more accurate, not because I think there are more people with seizure disorders. But there are about 3.5 million people in the US living with epilepsy. And epilepsy is nothing more than the condition where you see 2 seizures separated by time, or 1 seizure with the fancy word is propensity of experiencing a second seizure. So about 1 million live with medication-resistant seizures. So that's about 1/3. And of this group, 100,000 plus people are predicted to be surgical candidates. And if you see the slide the way I hope you do, we complete about 70,000 continuous EEG monitoring studies per year in the United States, but we perform about 3,000 related surgeries for epilepsy. So 100,000, we'll say, people are candidates for surgery, but a fraction of that go to surgery. So that alone should raise a red flag for a shortage of high-level epilepsy monitoring units, philosophies potentially of our patients, ourselves, and what is surgery and how is this conveyed to people from the providers. So I think it's important to really educate like today so we all understand this in a way that makes sense. And this to me is a partnership. This is not, top down where, I know something you don't. It's really, something clearly about epilepsy and how it feels to live with it. And now we have so much information in the world. We want to be able to funnel this correctly. So lastly, this statistic hasn't changed much. On average, we'll stay with adults for now. An adult living with uncontrolled epilepsy takes 19 years to be referred to an epilepsy specialist. That number has varied just a little bit, but you're still at this high number. So what's the solution? As I said, education, access to specialized care, and really this type of discussion. And I hope this will be a two-way street toward the end of the hour. So this is my purpose for being here today. So let's see if we can do a little bit more here. So at any comprehensive epilepsy center, and there are about 200 top-level, level 4 centers in the country, there we have 5 pillars that are important for both diagnosis and treatment. There are actually about 40 next step down levels, level 3 centers, we say, that do almost everything, but not all of the surgeries and maybe not all of the resources, but a lot. So, we think about medications. This is what we think about often when we think about a condition or a disease process. And remember, epilepsy is a condition, not a disease. The disease is what triggers the seizures. Now we have the diets, the epilepsy diets, from the most restrictive ketogenic diet to the least restrictive, the low glycemic index diet. What we know of as resection, or now more recently ablative, where you can just take away and laser away a very small area. And resections have been done for actually over 100 years as well, which is amazing to think that way. The modern era really has only begun in the 90s and up to now. And then stimulation. And again, this is our neuromodulation pillar that we're going to talk about. So I am going to present the VNS. We'll talk about what that is, the RNS, and also the DBS. And then behavioral health, can't forget that at all. It's a huge pillar that I want to make sure people understand. Okay. This just maybe a little shameless marketing is our center here. We're exactly 3 years old this month, and we do offer really all of the workup that you would expect at the highest level epilepsy center. There's a lot of technology involved, but also I'd like to think a lot of partnership and handholding and how we look at behavioral health and the connection with the technologies here. So the connection really doesn't just come at that synaptic level, but all the way to the community. So that's really what matters most. And that's all I'll say about us. So, resection is something that involves taking out a piece of brain. My apologies, this is the lunch hour, and I don't want to be too insensitive here, but here's the good news. This individual, there used to be a date on this slide, is from 2006. My patient for nearly 20 years went seizure-free after a very small area was resected. Had been seizing since really infancy in the jungles of Borneo, with really parents were missionaries, and with the mapping, when it had been done really well, we actually helped this patient never seize again. Now, the patient remained on a single medicine, but did really well. And it took a lot of effort to do this. And it was near, but not in, what we call eloquent cortex. And that's cortex at the surface of the brain that's involved with special function, and here's my little example here with all these colors. That typically is eloquent cortex. Here's the green in the frontal area. We incorrectly call this silent cortex. It's for processing and organization, executive function, we say. But there is still some function there that you care about depending on where we resect. But what we often understand best is the motor cortex, the sensory cortex, the visual, the language. This is the left side, so receptive language, vision, and memory. And you've got to know what's working and what isn't. So you got to stay out of those areas. Now, if you're in eloquent cortex, or this is in more than one place, for starters, then resection becomes a real challenge. The variation of resection more recently is laser, and our lasers are not hot enough or powerful enough to zap big areas of tissue. These are very weak lasers that get cooled by even blood flow, and it becomes not so useful. So that area that you see in more of a beige area here is the hippocampus, and you can actually take away very selective areas of brain. And I think that's so critical here. And all it takes is a small hole in the back, or basically is near the occipital parietal area in the back of the skull. And it's done within an hour, and patients recover so much faster than the open surgeries. But you got to understand, it's very selective in where we can resect. And if the circuit is bigger or bilateral, you really don't ever take out both temporal lobes. You become amnestic. You can't learn. And so it still is limited in, the candidates that can get ablative surgery. When we look at neuromodulation, we're looking at a history here that goes back pretty far. We're almost at that 100-year mark in modern history. We're going to stay away from the Romans. They actually used electric eels and other things, which, is interesting in itself. But in the modern world, we started long ago with actually stimulating the cerebellum. And this is a clue that we had pathways that can extend from one part of the brain, in the back all the way to the front potentially. A lot of these studies were not controlled, so it's hard to get real data that can be, copied and pasted to individual patients. You really needed really well-controlled multi-center data that really was overseen by the FDA in this country. We have some people outside of this country too, including Mexico, which should not be ignored. The Velascos really did some very impressive deep brain stimulation work. Then in 1988, and this was the inventor official who really looked at connecting to a cranial nerve, the vagus nerve. And just like we've been talking about, propagating current through it to get to central areas in the brain. And these networks were actually modulated in a way that actually aborted seizures. And it took a while. And actually, the first one, we don't hear this enough, was implanted in 1988. And then this device was approved in around 97. And we then started using this for treating seizures. And these are medication-resistant seizures. And that means someone who has failed at least 2 meds at the maximally tolerated doses. And at that time, actually, there were only about 4 to maybe 5 meds out. So more candidates out there, not a lot of options. And that, like I said, brought us into what we call the modern era of epilepsy care. Even though so much has changed since then, it still brought us to a place where we can look at a lot. And then we looked at around the same time, the deep brain stimulator, which I'll talk more about, and Dr. Robert Fisher out of Stanford, and then our responsive neurostimulator, which we'll talk about as well. So that's Dr. Martha Morell and NeuroPace. So we'll talk more about those and stay away from all that's to come here, but I'm going to show the future a bit. Okay, I think it's so important to show that. So let me start with the vagus nerve stimulator. Okay, and this is a device that many of us have heard. It really is, and you may not see me so well, but you can almost see this picture right there. And it's talk about interfacing with the brain. Here's an actual interphase wire. You can first notice that it's rubbery. So this is really a silastic type of material. And I can't even do this well, but let's see if this refocuses, catches, get out of the way. This is the wrap. It's more like a pen spring. I can't show it. There we go. That wraps around the vagus nerve in the neck. So it's already pre-spiraled, and the surgeon just pulls the string and it wraps around the vagus, which controls, it's one of the 12 cranial nerves, but it controls a lot of automatic body behavior, so from heart rate to gut motility, urination, and it's a two-way street though too, and it capitalizes on that to get into the brain, and it's just under the skin, subdermal, and it has gone through many generations now where you actually get feedback And we'll talk a little bit about that if I can show a picture here. This is the actual stimulator with a wireless wand and the one of the iterations of the programmer. This interesting new model, so far still called the newest model, the Sentiva, was released in 2017, and it actually allowed us to bring the age of the patient down to, it wasn't clearly this device, it was just at this time we were able to implant much younger kids, well before the age of 12, and that which was prior to this date. And I'll talk a little bit about the next device, but that next device will be a device that we can program remotely, which is long overdue and being released, but I really am excited about that next step here. Around 2015, 2016, we actually started looking at receiving information from the body, and that was, before that was a one-way street. This is heart rate, and let me show you a little bit about that as well. Heart rate accelerates in a majority of people experiencing seizures of many kinds. You don't have to start shaking or have so many terms, tonic-clonic seizure more recently, before that secondarily generalized convulsions, but that type of movement really requires a lot of blood flow and increased, contractions and rapid heart rate. But you can be staring off and you can see an acceleration of heart rate because you hit those centers. And so this can take advantage of this as what we call a biomarker to understand when that seizure begins and actually change that stimulation parameter set beyond what it does every few minutes. And there is a set of parameters here too, and I'll show you that in a moment. But this is what we call ictal, tachycardia, really the seizure onset. And here's let me just show that. I do think those numbers are higher than 82% of our patients experience an acceleration of heart rate. We do have a number that actually can become bradycardic. That is much less common, but that also is something that we can accommodate here. But the design of this device, what we call the two-way street or feedback or closed loop approach, was really to understand tachycardia or acceleration of heart rate. That ramp up is much faster or steeper than exercise. And so you can change that so you're not, getting stimulated when you're running up the steps. And this is called the auto-stim mode, and this goes beyond the regular stimulation every few minutes. So these are the parameters. Again, you don't have to really write this down so well, but we have what we call the output current, and then the size, or the sort of shape of the waveform. And I like to used to say every company has their own favorite waveform, and really this does have to go through the FDA, and it's safe, and it doesn't cause problems in the body. It does not injure the body. This is a big deal. And then the on time and off time. And I think that's crucial to getting a good effect. And it's taken decades really to understand what the proper or optimal stimulation settings are. And we're still learning, but we've come a long way with understanding how this works and what works. That wasn't the case when the VNS originally came out in the 90s. This is a slow process. This is the Sentiva. Okay, we call this also the model, or M1000. And this model is small, and it has certain settings on it. You can see basically four. I left the word voltage in there because I want to make it consistent with the other devices. But really, you're looking at current, which is, it's voltage, but just a different way to make your equation. This is what we call a constant current device. And the settings are beyond the optimal settings here, but these are optimal settings that you're seeing off to the side. So we measure this in milliamps. You put your finger in a wall socket, that's in amps. You don't want to do that. So this is 1,000 times lower. And then the pulse width, again, together, that gives you the actual dose. So it matters. And then the on time is by standard or factory default, 30 seconds on and 5 minutes off. And then there's a frequency too that we look at. One thing we often don't pay attention to, that there's sort of a negativity, and then there's a positivity, sort of a beautiful wave, like a sine wave, an S wave. Drop a pebble in a pond and you see the beautiful undulating wave. That's an up and a down. And you want to balance that in the body, no matter where you stimulate, because otherwise you can injure. And so this is what we call a charge balance. Negative is balanced with positive, biphasic waveform. So all that matters. You can see what it takes to put some of these devices together. A lot of this had, originally been tried in animals. This is a nice older study from 2004. Lots of very famous people here. Some of them not alive now, but what we showed here with PET is that even with hours or day, you can see blood flow changes, and that's over to the left, your left, looking at the screen, and with low stim and higher stim. And what happens, and then over days at least, and this is really short, but back then it was, what we call acute and chronic, and you can actually see changes, the blood flows changing, and this is a representation of metabolism in the cells. And this already, at this point, hours to days, is telling us that the brain is already accommodating, it's remodeling, okay? And I'll come back to this when we look at longer term studies, but this is really the beginning to say, hey, there's something, this device that is being connected to the vagus nerve way out in the neck is doing some really impressive thing in different parts and sectors of the brain. And these are like, geez, many, many, many centimeters away. So very impressive. So I'm going to just move over a little bit, because again, I want to give room for questions here. This is the deep brain stimulator. And this is probably as rigid, we'll say, as the VNS, in that there are two depth leads, and they always go in the same place. And this was the Dr. Robert Fisher trial through Medtronic that placed these leads in one part of the relay center in the brain called the thalamus. And the thalamus, again, if you can see, is right in the center, right here, above the midbrain. Here's the pons, the medulla. So right there's the thalamus. And it relays sensory and motor information. And it's actually in the anterior part. So we call this the anterior nucleus of the thalamus, or ANT. Don't say ant, but ANT. And that area really connects to the frontal lobe, which is really interesting, and then parts of the temporal lobe. So it's more of an anterior circuit that goes around. And it really is meant to modulate this bigger circuit. And why would you use this? Well, let's just say the VNS is not appropriate, or we just didn't have responders to one technology. And so this would then be implanted if these patients meet criteria, which also means we've already said, hey, this patient's not a resection candidate. Maybe they're multifocal and they're in eloquent cortex, but on both sides in many places, or we don't even know where exactly, but it is in the frontal temporal areas, okay? And with that, the goal was to see a decrease in seizures. Now, one thing I didn't bring up is for the FDA, this is a 50% reduction in seizure frequency. And that is not a lot, but that gets a device to that place where you can say, hey, this actually works. So it's meant to ameliorate or to palliate or to improve seizure control, and we'll throw in and severity. So I think that's important information here. And so in 2010, this was the data, and again, it was a pretty efficient study, but it didn't last too long. A little over 2 years, a year plus, but was sent in 2010 and started in 2008. That's where it was implemented. And so the FDA, so listen closely if you're not paying attention. I want to say two things, and they're going to be opposite. One is the panel recommended approval. Okay, but there's a two-step process, and the final decision at that time was it wasn't approved, and that is very sad. So, and it came down to a discussion of the data itself. The decision was split, but it just didn't get to that point of approval. Here's an example. This is one of our patients from where I came that shows the electrodes in the thalamus. And so what happened was it did get used, though, in Europe and Canada, and so data started flowing in. And we brought this back, and we, as in Dr. Robert Fisher and Medtronic, and looking at the data over time, and then getting more analyses, and then inevitably it was approved in 2018. So 8 years went by for this country before we could see it used. No editorializing, but it really is a point where we lost the ability to implant some of our own patients, and it showed a robust set of outcomes. And here's some of that. So here's what we can say, and this is how these studies look. And this is a publication from 2015. So the median percent seizure reduction from what we call the baseline seizure frequency was actually, as this continued to stimulate in the patient, a 69% reduction. And I'm going to compare it with 1 year, which was something. And then here's what we call the 50% reduction in seizure frequency, and that is what we call the responder rate, okay? And you can see the improvement over years. One thing I want to say right now is that basically these devices were not tweaked and adjusted overall through this time frame. It really was a remodeling effect that played the dominant role in looking at what we call efficacy. And that says a lot. It's not just breaking up a seizure, but it really is changing the number and efficiency of connections in the brain. This is synaptic plasticity. This is learning how to stabilize the brain. Impressive when you think that stimulation is improving stability of our fragile neural networks and not worsening. So I hopefully underline this well enough that we're looking at a reduction in seizures. But with that said, here's a seizure-free group, for at least 6 months. And at 5 years, that was about 16% of the group, which is a pretty significant number. Okay. So no reported and anticipated events. There was a question here. I'm going to bring up mood, of a change in mood. And the question was, did it make mood worse? Did it not? And that data was not hardened. I do want to say at this time we did understand how the VNS improved mood, and it was even approved for refractory mood, not the DBS, but the VNS for those who even failed electroconvulsive shock treatment. That's the VNS. So we know that stimulation does have a positive effect on mood, and that was not so clear for the DBS. And so that, the verdict was out, at least where it was being implanted. And here it almost looks exactly like the VNS. In part, this is the picture, a little thicker, a little bigger. And here, again, the same parameters we looked at. So I left it at volts, and this truly at that time was volts. It's 5 volts. And it was charge balance. If you shoot to the bottom of the screen, just so you know that the negativity up is the same as the positivity down. And then the pulse width, which is a little bit different than the VNS, not too far off. And then the on time for the VNS, now this is the V, was 30 seconds. This is 60 seconds. And then the frequency right there, 145 hertz. For the VNS, you may or may not remember, it was 20 to 30 hertz. So a little bit different, but still, you can see, the challenges with how do you, looking at data and understanding how what are the best settings. Okay. So I did get approval to show this when I did this study. This is, again, my apologies. I showed a brain picture. Now I'm showing a little cute animal picture. But this is a study that I worked with animals for 30 years, and this animal did really well, but this little guy had temporal lobe seizures. And so what we did, because there was no real animal data for one of these studies, we stimulated the hippocampus. And what you could see is there's a stimulation artifact in the middle here that changes the stimulation of that circuit. And the brain, it's a model of more complex brains, but you can see that stimulation itself in just a day can change the seizure frequency. So this is not implanted in the vagus nerve. This is not implanted in the thalamus. This is implanted directly into the hippocampus. Okay, and that's a big deal because now we're going directly into that target. And it does open the possibility of actually implanting in eloquent cortex. You can actually hit that cortex and try to abort that synchrony. And so this takes us to the responsive neurostimulation system. Okay, so the RNS. And this RNS system is something that was really envisioned before the year 2000. And I had nothing to do with this, but we were among the first sites to look at this, and really it allows you to implant 2 leads, each with 4 contacts. They can be either in the brain as an adept lead or on the brain as in a subdural 4 contact or a combination. And it's what makes it even more interesting, other than hitting the source, is that it's an implantable EEG. It's the first device that actually doesn't, the heart rate was a big deal for the VNS, but this actually looked at brainwaves. And again, this was back in 2004 when we implanted the first patients. And here it is, and you can see here's a combination of a depth lead, 4 contact, and a subdural. And this, interestingly, was submitted to the FDA in 2010 as well. Took a while to get through, so it's a lot of data, like nearly a room of data, boxes of electrocardiograms and lots of information. And it got finally approved in 2013, in November of 2013. And the first one to be implanted, the first was in California, the second was in Illinois, and they both were, that was post-approval. It was around, the circa 2014. So this again allows us to play around with lots of polarities, and there are a number of settings that are a little more than what we see with our other devices, but still I'll show you how similar they are too. The interesting thing is that a patient gets to take home a device, computer, and then download through Wand into their laptop, and then the laptop gets connected via internet and gets uploaded into a database at NeuroPace, which happened to be in Mountain View, California, the famous Silicon Valley area. And then anyone who is at that site, like a physician for that patient at their clinic in that institution, can look at that data. And it allows us to, on the fly, understand if they're seizing, if they're not. The patient can call you and say, I had a seizure. And then we can then bring them in to adjust. They have to come into the hospital. And here, this is, again, I'm trying to not show too many numbers, but this number almost looks exactly like the DBS at 3 months. This is a 3-month. The DBS numbers I showed you at a year, and you can see a decrease in seizure frequency, 41%. So this is a mean percent change from baseline seizures compared with when the patient wasn't on. We kept it off and didn't tell anyone for a period of 3 months, and then we turned them all on. So you can see this is not just the electrode being placed in the brain and the irritation of surgery stopping the seizures. So, and this was a big deal to show this back then, that there was an effect. This is a big deal. This predated the DBS. It came just after the RNS. And here is, again, this is the second patient ever implanted, and this was back in 2004. Post FDA approval was 2014. And so this thing both detects and stimulates. You can see the battery in the device. There's a chip, and then there are 2 ports. And here's an example for that patient with a seizure that got stimulated, and at 2 different, 1 parameter published setting here is just milliamps. Now there are many more settings. And it looks like it's associated with aborting the seizure. Sometimes it's a coincidence, but if you see it enough, you might just believe it. Here's another patient. This actually is the first patient in Illinois in 2014 post-approval. And this patient went from long episodes, and this is actually calculated by the system. So with the device and the software, you can see how many what we call long episodes or seizures went down to very low. In fact, this patient now, as of yesterday, because I'm still following this patient, is seizure-free and has been seizure-free for years. One thing I want to show you here is that this is, you see Y2, Y3, Y4 at the top. This is the years that pass with our patients. And there are a number of patients. And you can see without, you might be making some changes, but you're not making dramatic changes in everybody. There's an improvement in seizure frequency. The responder rate, we'll call it 50% reduction minimally, is improving over years, okay? And this is something that it's not like you give a drug dose and it works and then it doesn't, or it stays stable. This is still improving. So we're seeing a remodeling effect over many years here, and that's a big deal. This maybe is a lot of data here, but this is an experience from Chicago that I put together in the early days. And this is the actual full trial, multi-center trial. Most of our patients were placed, the electrodes were depth, placed in the temporal lobe. And actually the insertion site was in the back, just like the ablation surgery that I showed you that took out the hippocampus. You actually can go from occipital through the visual cortex, which is interesting, and go right into the hippocampus itself. And they did really well. And that's a big deal here. But you can also implant them in basically any cortical region. And more recently, we actually are implanting them where the DBS has been studied, and that is in the nucleus, but in different parts of the, did I say that right? In the thalamus. So in the, not just the anterior nucleus of the thalamus, but also in other parts of the thalamus. Okay. Thalamus are composed of nuclei, we say. And here is that RNS, and you can see, again, I changed the word voltage to current. And there's standard settings, pulse width, that's just, again, the width of the wave that we're sending in, the burst duration, and then the frequency, not too far off from the DBS. Okay, and it's a charge balance. The up E is the same as the down E. You've got positive, negative balance in that waveform. So we say you don't electroplate the brain that way. And again, the current times the pulse width equals the actual dose. Like the drug dose, this is the dose. And here, charge density means the number of electrons you're flicking off the metal into the brain, off the surface area of metal. And, that gets you that control, okay? So I want to show you something here. This is something I put together a while ago. This is an actual monkey brain. So it's an macaque monkey brain taken to IBM, and they looked at over 600 plus studies, technically over 400 plus, and looked at all the connectivity. And this is how parts of the brain, you can't really see the abbreviations, but this is how the brain is connected. And one thing, what I've shown you is that we are connecting to circuits. We're not just hitting the spot. This is a network problem. And, we talked about 3 devices, but there are devices for pain, there are devices for depression, and there are devices for other pieces here, even being studied for Alzheimer's disease. And I want to show you something. So we studied those 3 devices, VNS, DBS, RNS, but look at all of this that you can, if you stimulate certain circuits in the brain, you actually are treating that area. It's not just that this is the holy grail or spot or, the target for the bullet. It really is the interface of a circuit that means something. And to prove this a little bit more, here's a little study we did a while ago looking at a patient who is now seizure-free with the RNS, where you can see the little arrows here where I have a contact showing on a CAT scan that's co-registered to an MRI. And then we stimulate without the patient seizing, and then we inject radioactive material on this scanner called SPECT scan. And what we see is if you stimulate in one area, you actually cause changes across the brain. Not just in one, in various stages, places, depending on where you stimulate. And this is at 4 months after the implant, this is at 3 years. And you can see, and we've done this a few times now over in a number of patients, that you're actually changing different areas as far as metabolism and demand and blood flow patterns. This looks at blood flow, which is an indirect measure of neuronal metabolism. So if you remember way back when for the VNS, I showed you the slide that showed this change within hours to days. This keeps going. And again, this is now our work showing that, hey, you're getting remodeling even if you're not changing settings on the brain. This may be a lot. This is really just nothing more than what I said. Availability, we talked about where really in the United States, and OUS is outside the US. The VNS and DBS are available in a number of countries now. And really, the RNS is potentially more targeted, but I think for all of these, you are now looking at the network. So we are thinking about networks and where to implant. The DBS still gets implanted into the thalamus, though, over here. And the side effects are good. You hear about the VNS and hoarse voice, and you get a vibrating voice that often the person doesn't quite get concerned about, and sometimes you don't. And you can give me a lot of stories, good and not so good. But everybody is so individual that, it depends on so many factors. But again, the VNS has the most data now because it's, it had a head start, and probably, not even probably, it is the most, let's say, elegant to implant, the least challenging, because you don't have to do a lot of mapping in the brain, and it doesn't go into the brain. So here's my dream of, well, how do you choose now? Which one do you choose best? And first, all these people who are candidates must be medication resistant. So they have to fail at least 2 drugs. Now we have more therapies, from meds to diets to, even we can think about relaxation training. But this is a big deal because you want to, if somebody has a seizure and they get hurt, that should be intolerable. And one thing we do as humans, we adapt to adversity. And the goal is not to adapt to adversity and also do no harm. So we want to really understand how we can therapize somebody, again, with noticeably benefiting them and not hurting that person. And so the VNS, RNS, and DBS really do stand above medicines when you look at how well they work. In a busy epilepsy center, so we say the highest level is, roughly 3,000 patients. We monitor, sorry, I said that wrong, 3,000 continuous EEG monitoring days, which means one patient could be monitored for 3 days. So that's 3 monitoring days for one patient. And each patient, is an admission. And at the biggest centers, we admit on average 350 patients per year. And this is still, there are a lot of unmonitored people who don't get worked up well. And you really need to understand that weather map of somebody before you go forward with any of these studies. So even with the number of centers we have now, 200 level 4, 40 plus level 3, not enough. Okay, far from it. So we still are short on trying to assess our patient, and we really should be looking at surgery earlier. Not that we should be pushing it hard, but it should be on the table and explained well in tandem with all these other therapies that we have. Okay, very briefly, I just want to go quickly. This is the next step for programming the VNS, and this is something we looked at the onset of the pandemic. And in 2020, we were able to do this, even with the technology we have. But it's not approved by the FDA, so we were kind of off-label here. So the company is looking at this in a more appropriate way. But we can do these things at a medical center, and we were able to do it. That's a real patient that had their VNS programmed from 80 miles away. We're 80 miles away from that patient programming her. So I'm excited to say that we were able to do this. And even when you look at that abstract, this was 9 years ago, we were doing this with the RNS, the responsive neurostimulation system. And that's on the docket too, as far as doing this hopefully soon at some point with programming remotely. But this is, again, it didn't take much effort, but this is from a computer standpoint without hacking the system or anything like that. It becomes an elegant way using some technology that is appropriate but still off-label. And this is, again, about 60 to 70 miles away from Chicago. We programmed this individual near the Wisconsin border back in 2015. So I'm cutting it off here. I want to just hopefully maybe open eyes a bit wider. I think everybody is now sophisticated with what we can do, and Google, and now with AI, we can look at some very cool things. You can even ask your AI, Gemini, whatever you want to say, Chat GPT, some questions, and they'll give you some nice answers here. But it's up to us, the RI, the real intelligence, to really sit down as, a partnership, you as the intelligent person and the provider, to really talk about these options as part of the bigger picture of how to stabilize epilepsy and to improve quality of life. So I'll stop there.
Thank you so much for that fantastic presentation, Dr. Rossi. Does anyone have any questions at this time?